Good morning, ladies and gentlemen. You seem like a full house. Okay. I have been given this task to talk about paravertebral block for surgical anesthesia during breast cancer surgery. Some of the lessons I have learned, I would like to share with you. Now, I'd like to see a show of hands. How many in this audience use paravertebral blocks for breast surgery in a clinical scenario? Can you raise your hand, please? Okay. How many of you in this audience use paravertebral blocks for surgical anesthesia in breast cancer surgery? Oh, there are quite a few. That's good. But my question today is, does it really work? I have been chasing that dream for more than 15 years. Today I have the answer. And I will present to you a sequence of events that, with the science behind it as to why paravertebral blocks may work or may not work. Anyway, I have no conflict of interest, but I will be presenting some unpublished data which are in the process of being reviewed and will be published soon. So these are my objectives. I'm going to review some of the anatomy of the breast. Unfortunately, the anatomy of the breast is very poorly described in the anesthetic literature. Then talk a little bit about the basics of paravertebral block, because without the understanding, you will not know how to apply it into clinical practice. Then I'll tell you what works and what does not work with objective data, and then introduce you to a new concept of subpectoral plexus block. Now, I know I'm studying between Michael and T. I will try my best to complete this in the next 20 minutes, if I may. Whenever you see a star, that means that's an important take-home message. If your mind is wandering, please come back. Now, today, we know why we use it in breast cancer, because breast cancer surgery is described to be very emetogenic, despite the use of anti-emetic agents. The patients still have nausea and vomiting. And I think as our practice of anesthesia has changed from not using nitrous oxide in many centers like ours, use propofol, regular anti-emetic agents, I think that incidence has come down. So today the focus is more on long-term outcomes, particularly chronic pain, quality of life. And there are data that say that paravertebral block may improve long-term outcomes. So in order to really understand this, you have to have a good understanding of the innervation of the breast, one. Two, you need to know what kind of tissue destruction actually occurs during the breast cancer surgery, the primary breast cancer surgery. It took me a long time to really understand all this. And maybe most of you in this audience probably do not still understand. I would refer you to this article by Dr. Glenn Woodworth. I think this is an excellent article describing the innervation of the breast, the tissue destructions. So I'm going to talk a little bit about the cutaneous innervation, which we often think is what you need for breast cancer surgery to be done under regional anesthesia. But actually the innervation of the parenchyma, innervation of the axilla, and there is growing data that maybe the muscles are also involved in afferent nociception. Because when they do breast cancer surgery, primary breast cancer surgery, they do the surgery on top of the pectoral muscles, particularly the fascia of the pectoral muscles, and I will come to that shortly. The intercostal nerves, particularly the T1 to T6, are involved with innervation of the cutaneous innervation of the breast. It is through the medial branch of the lateral cutaneous nerve, which forms the lateral mammary nerve, like the lateral mammary nerve here, and the medial branch of the anterior cutaneous branch of the intercostal, which forms the medial division, is the medial mammary branch. Laterally, you have from the T2 to T6. So the intercostal brachial nerve supplies the axilla, and the rest supplies the lateral mammary nerves. In the medial aspect, it is the T1 to T6. These are the medial mammary nerves. The axilla is innervated mostly by the intercostal brachial nerve, but there may be contributions from the T1 too, because there can be quite variations in this. The supraclavicular nerve supplies the upper part of the breast, but in my clinical experience, particularly with modified radical mastectomy, the surgical incisions do not usually involve the area innervated by the supraclavicular nerves or the superficial cervical plexus. The pectoral nerves, which are derived from the brachial plexus, may be involved with afferent nociception. But the pectoral nerves do not supply the skin or the parenchyma of the breast, they supply the muscles. So they are often described as motor nerves. But are they really only motor nerves? We will come to that. It's also anatomically described that the pectoral nerves are derived from the lateral pectoral and the medial pectoral nerves, or medial cord. Sorry, beg your pardon, ladies and gentlemen. But actually, that's a very simplistic way of looking at the anatomy of the pectoral nerves. In fact, if you review the literature, there's a wealth of information available in plastic and reconstructive surgery literature. Sylvia and David demonstrated in cadaveric studies that the pectoral nerves are actually more complex than is described in the anatomical literature. Actually, there are three nerves. There's a superior branch, a middle branch, and an inferior branch. All these interdigitate and intertwine between the two muscles and deep to the pectoral muscle to form a plexus of nerves. So thinking of the pectoral nerves as two isolated nerves like the median nerve or the ulnar nerve is naive. Secondly, these are very small nerves, so if we are going to use ultrasound, you've got to remember that they all interdigitate close to the thoracoacromial artery. So this artery, in my clinical practice, is a very important structure because if you can identify this artery and perform your injection close to it, then you can take up most of the nerves that form this plexus. So remember, it's the thoracoacromial artery, it's the branch of the axillary artery. Also, the ansa pectoralis, which communicates between these various branches, is an important contributor to this plexus. Dr. Lee from South Korea demonstrated there are anatomical variations in the spinal origin of the pectoral nerves. They don't come simply from 5, 6, 7. It can come from 5, 6, 7 and all the way up to C8 and T1. So the spinal origins of these nerves are also very complex. So much so that Professor Lee has described what's today called the subpectoral plexus of nerves, which forms the superior branch, the middle branch, and the inferior branch, and this is part of the ansa pectoralis. This is our cadaveric dissection where we try to elucidate the subpectoral plexus. As you can see, as we split the fibers of the pectoral major muscle from anterior to posterior, you can see there's a rich network of nerve between and then deep to the nerves, very close to the thoracoacromial artery. There's also growing evidence that maybe the long thoracic and the thoracodorsal nerve, which supply the serratus anterior and the latissimus dorsi muscle, may also be involved with afferent nociception, particularly if you're doing axillary dissection or operation on the lateral aspect of the chest wall. Also remember, when these nerves traverse from their origin to the breast, they also carry with them postganglionic sympathetic fibers, particularly from the middle cervical and the stellate ganglion. So there is a rich sympathetic supply. This is a very busy slide, but all I'm trying to illustrate to you is that the breast innervation is more complex than you think. It doesn't only come from the intercostal nerves. In fact, if you want the coverage of the breast, you need a lot of paravertebral blocks. So today I understand you need somewhere between C4 to T6. Now, nobody in their right frame of mind would want to do so many multiple paravertebral blocks. So let's see now what kind of tissue disruption occurs during breast surgery. I go straight to modified radical mastectomy because this is the major operation today. While simple mastectomy is removal of the breast, but they do not remove the fascia of the pectoralis major muscle, in modified radical mastectomy, the breast is removed from the fascia of the pectoral major muscle. So now let's look at paravertebral block. Paravertebral block is a technique of injecting local anesthetic adjacent to the intervertebral foramina as a repository for local anesthetic. Is very unique because it not only contains the sympathetic nerves but also the somatic nerves. So when you perform an injection in the paravertebral space, it spreads to the epidural, intercostal, prevertebral route and to its contiguous spaces above and below. This produces an ipsilateral anesthesia that we know, but actually the mechanism is not only because of paravertebral spread. There's multiple routes through which it produces that unilateral segmental anesthesia. So the ipsilateral anesthesia that it produces is unfortunately very unpredictable. Because as you can see here in this study, the report by Dr. Chima and the group from Bradford, they showed that when you inject about 0.3 mils per kilogram of bupivacaine, you get about a mean of 5 dermatomes. But I think if you're a clinician, I would be looking more carefully at this range, which varies from 1 to 8. So on Monday, you may get a 5 dermatome block, but on a Tuesday, you may be stuck with a 1 dermatome block. So that's not very good. It has its limitations. As you can see in this series of chest radiographs showing injection of 10 ml of a radiocontrast medium through a paravertebral catheter placed at T4, T5. The spread is very variable. This produces unpredictable anesthesia. Age, gender, weight, height, the dose of local anesthetic or the volume of local anesthetic you inject into a single paravertebral space does not influence the segmental spread. As you can see here, as we increase the dose of bupivacaine, there's a very poor correlation in the segmental spread that you see. As you increase the volume of local anesthetic, by increasing the volume of local anesthetic, you will not be able to increase the segmental spread, particularly if you're doing a single shot injection. The onset of paravertebral block, this is with 0.5% bupivacaine, is also relatively slow. Multiple injections produce more reliable spread of the drug and segmental spread. So if you want reliable, consistent segmental anesthesia, then you have to do multiple injections. Today is the era of ultrasound. So does ultrasound blocks differ from the landmark-based technique data that I showed you? This work by Professor Marhofer from Vienna showed that when they did ultrasound-guided blocks, you can see that the segmental spread is also quite variable. But more recently, a work from Canada, Dr. Sue Ganapathy and the team showed that actually there are no segmental differences if you use a single or a multiple injection. There is no statistical difference, ladies and gentlemen, but I'm still waiting to see if these individuals can use this for surgical anesthesia. I can bet you, no. So, how do you use this technique during breast surgery? You can do a single injection, you can do a multiple injection, which is usually between T1 and T6. So for simplicity, let's call this the 6M. And you can use it as a continuous catheter. Single injection usually performed at T3, T4. You inject about 15 to 20 mils of local anesthetic, and you get an ipsilateral block. So now, ladies and gentlemen, I think you would agree if I said that if you did a single injection, do you think it will be effective for surgical anesthesia? No. It will not be reliably, consistently effective. Maybe one day you're lucky. Particularly if you're doing breast surgery that involves removal of the breast from the pectoralis major muscle, that is the modified radical mastectomy. Maybe it would be effective if you did a lumpectomy, if you did a segmentectomy, you did a quadrinectomy. However, it is effective as a technique that produces good analgesia. We've also demonstrated that single injection is a very powerful tool. It reduces not only symptoms and signs of chronic pain at 3 and 6 months, but also improves quality of life, particularly physical and mental health. More importantly, we found that there were no differences in short-term or long-term outcomes whether you used a single injection or a continuous catheter. That's very interesting. So today we have abandoned the use of continuous catheters in breast cancer surgery, primary breast cancer surgery. Now you can use it as a 6M or multi-level injections. So the question to you is, like many of you in this audience who will probably use it for major breast cancer surgery, use it as a multiple injection technique. Do you think a 6M or a multiple injection technique would produce surgical anesthesia? Maybe. Let's look at the data. This is interesting data from the Duke in the United States when Dr. Roy Greengrass and the team showed that multiple injections produce surgical anesthesia with minimal complication, high degree of patient satisfaction. Even the surgeons are very happy. In fact, they were on the cover of the Times magazine. They were nearly on the cover of the Times magazine because it created such a buzz during that period of time when regional anesthesia was used in this group of patients. They also require less pain relief and so on and so forth. But however, the data is from a time when thoracic paravertebral was morely landmark-based. As I said before, we've moved on. There are multiple techniques of performing paravertebral blocks. In fact, the table is quite extensive. While Dr. Credit and the group have shown that you can do a transverse scan, sagittal scan, and you can do all kind of needle insertion from behind the ear, from front of the ear, from outer plane, in plane, etc. But they really don't tell you what is the optimal way of doing paravertebral blocks. Effectively, you can do either a sagittal scan or a transverse scan. In the interest of time, I'm just going to cover sagittal scan very briefly because I don't do this anymore. For some reason, the reason behind is that you can do a sagittal scan, and you can see here, even with a very high-end ultrasound system, visualization of the pleura is quite poor. We will go into more detail of this with some of you that come to the masterclass later. There's also poor visualization of the needle because of the acute angle of needle insertion. So much so that I believe this can be a dangerous technique if you don't use it. If you use the sagittal scan, there are more chances that you may puncture the pleura. I find the transverse scan more simpler. You use a curved array transducer. We use a transverse scan technique sequence identifying the osseous elements. As you can see, the transverse process of the thoracic spine are directed backward in contrast to the lumbar. There's also a valley that is created between the transverse process, the lamina, and the spinous process. It is this sonographic pattern that you can very easily recognize in the ultrasound. Also, I like you to note that the inferior articular process, which is this structure that articulates with the superior articular process from the facet joint, is very closely related to the intervertebral foramina. So if you can identify the inferior articular process, then you can very easily identify where the intervertebral foramina is located, and that is the medial or the medial aspect of the paravertebral space. So the sequence starts by locating the rib and the transverse process and the costotransverse articulation. You then slide the transducer slightly caudate to identify the transverse process, and then to the intertransverse space to look for the articular processes. And as I mentioned, the inferior articular process is very closely related to the intervertebral foramina. These are the three windows that you see here. This is the spinous process, that valley I alluded to, the transverse process, and the rib. This is a large acoustic shadow. As you go below the rib, you will see the spinous process, the lamina, the transverse process. And if you go to the target window, which is the inferior articular process, then you can see the entire paravertebral space. As I said, it's the intervertebral foramina is located anterior to this structure, so the foramina is located here. This is the superior costotransverse ligament, which is the posterior wall. This is the pleura. And this wedge-shaped space is indeed the paravertebral space that we are looking for. So when you look at this, you can see this is the sonographic patterns you want to identify in your mind's eye. And if you see, this is the wedge-shaped paravertebral space with this green structure, the intervertebral foramina. So today we can very objectively identify the paravertebral space. We presented this work and it'll be soon in publication. Today I have performed more than 3,000 individual injections in many hundreds of these patients. The conduct of anesthesia is quite simple. You position the patient in the lateral position because they have multiple injections. We sedate them, we give them some ketamine for comfort and analgesia. How you position the patient, you should spend some time because depending on your handedness, having the patient with the patient's head either towards the machine or away from the machine can help you a long way to using your right hand. We use dexmedetomidine, but we do not bolus the dexmedetomidine. We use midazolam as the agent for inducing sedation, and then any ketamine is used during the perioperative period for any rescue analgesia. Under strict aseptic precaution, we use an in-plane technique. As you can see here, the needle is introduced from a lateral to medial direction with the articular process window in view, and the needle is introduced with an assistant assisting you to inject saline or the local anesthetic, and this is the usual ergonomics that we use. It's an in-plane needle insertion with the articular process window. When you insert the needle is inserted like so. This is the no-go zone. You still stay at the apex of the paravertebral space. As you can see here, the needle is emerging from this point, and then you advance it into the into the apical part of the paravertebral space. You inject some normal saline to confirm that you are in the space, you're not intravascular, then you inject the local anesthetic. This is the no-go zone because there are multiple vessels in this structure. I'm just going to take a few extra minutes, okay? I'm sorry, this is important for you. Next is this is the setup. You can see our patients are listening to music, they have conscious sedation, and the surgeon performs major breast cancer surgery. Primary, this is like a modified radical mastectomy. So now I submit to you, ladies and gentlemen, and ask you this question. Will this 6M thoracic paravertebral block be effective as a sole anesthetic for major breast cancer surgery? It took me a while to really understand this. We present this work where we found that no, multi-level paravertebral blocks cannot provide complete surgical anesthesia of the breast. You understand now. You know the anatomy, you know the innervation, it's easy to understand. The paravertebral blocks don't block the pectoral nerves and the other affiliated nerves from the brachial plexus that are associated with this. Up to 80% of patients, despite they having a sensory block from T1 to T6, would experience pain. They require ketamine as rescue analgesia. They require small doses of ketamine. As you can see here, the mean dose of ketamine over a 90-minute surgery is about 40 milligrams as a 10 milligram bolus. This is the most surgical step which induces pain. As the pectoral muscles contract, the patient report a dull aching pain. So this is the first clinical evidence that the pectoral nerves are indeed involved with afferent nociception. So we should spend some time reflecting on this because the pectoral nerves are described as motor nerves. I think that is too simplistic, and I think that concept is slowly being challenged, including our works, because also the pectoral nerves do not innervate the skin. Also, we should question whether these nerves are actually motor nerves. Dr. Blanco has described a series of pectoral interfascial blocks. He describes the PEX1 as an injection between the pec major and the minor to block the pectoral nerves. I do not believe that if you inject an injection between the two muscles, you can block the entire pectoral plexus. I leave that at that, because there are no data today. So even possibly the PEX2 injection, which is injection between and deep to the muscle, is more likely to block most of the pectoral plexus. But his objective of describing the PEX2 was to block the intercostal nerves as an alternative to paravertebral block. We describe a subpectoral plexus block based on the work by Dr. Lee. And the injection is done close to the thoracoacromial artery. As I said, it's a structure that you can easily identify. This is how the patient is positioned. It's an in-plane needle insertion technique, identifying the thoracoacromial artery, deep to the upper border of the pec minor muscle. The needle is inserted between and deep to the pec minor muscle, where you inject local anesthetic deep to the muscle, close to the thoracoacromial artery, and as you withdraw the needle, you inject between the two muscles. Today, we do not know how much volume, but in general, I inject 10 cc's of local anesthetic, about 0.2 to 0.25% of local anesthetic. Mind you, we've already injected about 100 milligrams with the paravertebral injection, so I urge you caution and as to how much you inject into these plexus. It seems like 20 cc's as 2 10 mil boluses appears to work. This is the first injection, which is deep to the pec minor muscle. Okay? And then as you withdraw the needle, we inject between the two muscles. As you can see, the needle's been redirected. And the pectoral branch of the thoracoacromial artery can be a very useful landmark when you find that identifying this tissue plane is difficult. And that is quite common in individuals that actually come for breast surgery. In a randomized placebo-designed study, we've shown that the subpectoral plexus block actually reduces ketamine requirements, reduces interventions, and improves surgical conditions intraoperatively. If you see this now, there's a significant difference in the requirement of ketamine, the total dose, and the number of patients who require ketamine during surgery. So the subpectoral plexus seems to provide analgesia that is complementary to the paravertebral block. So paravertebral block, ladies and gentlemen, is a useful tool for breast surgery as a single as well as a multi-level injection. But multi-level injections do not provide complete surgical anesthesia. As I presented to you, the pectoral nerves probably are involved with afferent nociception. So the concept that pectoral nerves are motor nerves is incorrect. Secondly, when you do a multi-level paravertebral blocks, combining it with the subpectoral plexus block will improve the quality of analgesia. So I leave you with this because we have ongoing research now to say, do we need to do 6 injections? I can tell you from my experience that you don't need. You can do alternate 3 paravertebral injections and combine it with the subpectoral plexus block, you'll have great success. We are also looking at how does a multi-level paravertebral block affect long-term outcomes. Our preliminary research shows that multi-levels paravertebral blocks actually provide better attenuation of chronic pain in the long term. So I leave you with these thoughts, food for thought, and I thank you for your attention. And I thank you, sir, for the additional time.
Thank you, Professor Manoj. Dr. Bala.